We can now have a panel dialogue. I would like to ask the other two speakers if they have something to comment regarding the Barcelona PrEP point or anything else.
Nothing to add, but it's an interesting option we can learn from you, from your experiences, for example, for the Berlin checkpoint.
And I guess all I'd say is that this engagement with trials is definitely an important first step in terms of creating knowledge of PrEP in the community and beginning to put pressure on governments to think about the next steps once trials are over. We certainly found PROUD was an absolutely essential first step in England. So I think the tactic seems to be a very sensible one.
Maybe it's time to have questions from the audience.
Let's see, no, it's not. Now it's working. Takes a few seconds. I've got a question. One of the things that's coming up, and Dirk particularly brought it up, but I think it applies, is that there's a combination of terrific demand from educated 40-something gay men who are already aware, and not enough demand from people who don't fall into those categories. It's really sort of... so what can we do to increase... It's becoming clear that we don't just need to make PrEP available, we need to encourage health services to actually sort of advocate for it amongst the populations who may need it most. After all, we don't have any problems in terms of public health campaigns to try and make vulnerable people aware of other health issues. So what can be done to actually better spread the word amongst the people who currently could benefit from PrEP but aren't?
There are 2 points. Yes, we can do more promotion campaigns and try to reach those who are not well educated. I think I know a lot of young guys in Berlin who are at the university, and they could use PrEP, but they can't afford it. They don't have the money, and that's a problem. That's why I think the initiative of the Fast Track City in Berlin to cover for 500 maybe students or who cannot pay for the PrEP is a good example to come a little bit further in this point.
And I think the point about public health promotion is really key. And one of the gaps, one of the missing bits of the PrEP trial is there is no money going into the promotion of PrEP in relevant communities. We're going out into those communities. There's no additional funding available for that. It's purely clinic-based. So there's a gap. I think the other point to make when we look at the bias in terms of who's taking PrEP up, this isn't a new thing. This reflects age-old structural inequalities and a lack of prevention work in certain communities over many years, and a lack of resourcing of prevention in those communities. So I think PrEP is an opportunity for us not only to think about promoting PrEP to different communities, but actually doing basic health promotion around risk and the range of prevention options that are available.
Next question.
Yes, I wanted to say that I find the Barcelona example quite inspiring, especially for Germany, because there we have a big barrier. Dirk, you said the #1 barrier in Germany is stigma, but I think right now the #1 barrier is what happens when I want to get on PrEP. I can get the pills, but where do I go? To which doctor? How much is it going to cost? And some students just cannot afford this. And so this option of having a checkpoint with a prescribing doctor who can prescribe PrEP might be an answer. I think perhaps in Germany we need more checkpoints, and we need someone with the authority to write a prescription in the checkpoint.
Well, I think it was Julio this morning that they said that we invented the linkage to PrEP, not the linkage to care, but the linkage to PrEP. So having the checkpoints is the best place where to identify the people that could benefit from PrEP for sure. I mean, all the people that we have enrolled in our well, not in ours, but in the studies that we presented, mostly there were already checkpoint users. I mean, for detection of STI and HIV and other STIs. So we really hope that this inspiration maybe. It's not necessary to build a special place and calling them PrEP point, but the checkpoints would be certainly the good places to be offering PrEP.
Yes, just to add to that, I think that it was already mentioned. PrEP is not a silver bullet, but if you have normalized HIV testing and starting treatment early, it's just a complementary step. So if you're already reaching a lot of population and people are testing negative, then you have a good point to start talking about PrEP. And so it's important to, with the PrEP point, it's the same principle as with the checkpoint. It's transparent doors, normalizing the issue, and then mouth to ear promotion is a big asset.
So we have about 10 minutes. I see 5 questions coming up, and we haven't yet gone through the Facebook, so no question from the Facebook. Can we have the next question?
Thank you very much for the presentation. As a medical activist from Berlin, I would like to ask Dirk about your personal opinion about the PrEP in Germany from Exal. It comes in small little blister packages where the name is written on it, your personal name, and also your date of birth. So I would like your personal opinion on that version of a not anonymous PrEP in Germany.
Yes, I've heard that it's a problem, and this has to do with shame and homophobia. People don't want to be connected to a prophylaxis which says something about their sexuality, and that's the problem. That's what I meant in my presentation to say that shame and homophobia and the stigma on gay sexuality are influencing access to PrEP. So maybe this can be changed. I don't know if it's necessary to write the name on it.
Also, a question for Germany. Does your country have national guidelines available to help hesitant providers? Because they do play a role in making the prescription for PrEP. And we all know that they are sometimes a bit hesitant as they don't know a lot about PrEP. And does your, is hepatitis C testing included in your PrEP workup?
We are talking about including it in these regional projects. I don't know what you mean by national guidelines. There are guidelines that are sent to all the doctors, but they don't are not German national guidelines as far as I know. But there are guidelines sent around and information about what's important if you have a patient who wants to take PrEP and what are all the necessary examinations around this. Natürlich. Of course. I forgot to mention there are guidelines. I personally wouldn't see them as guidelines, but there's Beschreibung. There was this appeal from the Deutsche AIDS-Hilfe. We have all been working together on which recommended for doctors to help patients to get PrEP and to support them on their way.
Next question, please.
Thank you. Good afternoon, everyone. My name is Diogo Medina. I'm from the Lisbon checkpoint, so right next door. We're in a very similar position, I think, because we're also following about 70 men, so it's about the same thing. Lisbon and Barcelona share more than we think, that are doing online PrEP. We have had it approved by the government last June, much like Brazil and Belgium, but unlike Brazil and Belgium, we are very slow, and we still don't actually have it. The government says we're going to get it in about a month, but and to get to my question, we think, or we know that it will only be available through hospitals. We will also have it at checkpoint, but people will have to get the medication elsewhere. We've heard from many countries where in some you can get the medication at community pharmacies. That is the case of France, Belgium, Germany. In others, you can only get it at a hospital. We view that as a major barrier because of financial constraints and other aspects. I'd like, if you could, to elaborate on what's the situation like in Spain. Can you also get it at a community pharmacy? And if that's not the case, what are you doing to change that? Because we also need inspiration.
Well, Spain is a very complicated situation on this issue. There's a law which says that this kind of drugs should generally be provided throughout hospital pharmacies. So that's clear, but the generally implies that there's a room for interpretation. And as there is the Association of HIV Specialists in Spain, which provide the guidelines for antiretroviral use, they foresee that if you want to use PrEP and you want to have a good uptake, that probably the hospitals are not the optimal situation to get there. So that's why in the Spanish guidelines, where we're lucky enough to participate in those, are incorporated these ideas of including other kinds of places where medication can be provided. Now, the feasibility study, which has started from the Spanish ministry and from the Catalan ministry, one of the goals is to see in which places it can be provided. So there's one hospital in Baskeland, there's one STI clinic in Barcelona, and a community center in Barcelona, which are we. So I can tell you that the problems they had with recruitment, in the Basque hospital there are 12 persons recruited, in the STI clinic there are 10 people recruited, and in the same time we have 162 persons recruited. So it's an evolving situation.
I just want to add that there is a precedent. Maybe we can take as an example methadone, that is a drug that was prescribed and usually distributed or delivered in hospitals, but nowadays methadone is even distributed through metabuses. I mean, no one could expect people in use that needs methadone to approach the hospital so easily and going there every day for the doses. I mean, so we have to take that what the legislation permits, and maybe it would be a good example. We have to reach that population, and so maybe some agreements with some hospitals, even the pharmacy is the pharmacy of the hospital. The law doesn't prevent to deliver the drug in a community center. I mean, even though the pharmacy itself of the responsibility of the drug is not in the community center but at the hospital, and that's the kind of agreement we have tussen Germans Trias I Pujol, one of the most important HIV units in Barcelona, and our community center.
Allow me a comment. Unfortunately, in Greece, it's a very centralized OST system, so you only get it from hospital, which is, since we're talking about imaginative solutions, we can learn from other situations or communities like the drug users. And of course, we see that we must engage with all kinds of healthcare professionals, either pharmacists, doctors, because it's a drug. I mean, you must have them on board. So. Next question.
Thank you. Just quickly, I think we sort of touched upon it in terms of the notion of medicalizing PrEP and having sort of key population-led services for PrEP. Maybe your thoughts on initiating people on PrEP on the same day as they come in versus, like, obviously and given kind of these issues raised that you can't deliver PrEP drugs, at the sort of facility where people are getting their HIV tests and presenting. So some thoughts on that, if that's too ambitious or actually that's kind of the way we should be going.
Completely agree with the idea. That's one of the key issues I mentioned is point of care technology. So what we do is viral load testing. So try to have the window period as small as possible. So I understand that people could start really on the same day if you do all the tests, and then you will check after 1 month. So if somebody was in the window period, you will be in place there to modify the antiretroviral regimen.
Just to say, Gus talked about the PROUD trial. I mean, it is possible to do the PrEP impact trial. You can start on the same day. You're asked questions about your sexual history, and if seroconversion is suspected, of course, then not. But otherwise, you have a point of care test and also a blood test. And should it emerge the person has HIV, then they can move on to the full regimen.
Your name and affiliation, please.
I'm Mark. I'm from Malta, currently based in the UK. With the ever-increasing decrease in budgets, in the NHS budgets for sexual health, with 600 people being turned away every week for testing, do you foresee any problems with the PrEP rollout on the NHS after this trial would have been completed?
Yes. I mean, one of the advantages that our health system is incredibly complicated, and for PrEP actually to be delivered, you need 2 organisations to be involved. You need the NHS to pay for the drug, and you need the local council, because the local councils actually pay for the sexual health clinics in our country. The advantage of the trial, which I didn't have time to mention, was that in the 3 years of the trial, the NHS is also paying any additional costs for the local council. But the local councils are absolutely under immense pressure. Their budgets are being cut. Sexual health clinic funds are being cut. So this question of how do we move from the trial to routine provision, we are going to have to, at that point, persuade 150 local councils in England all to step up and play their part at a time when their budgets are severely decreasing and they're not keeping up with demand. So that is the next stage in the policy advocacy. We've had a lot of victories, but we're absolutely not there yet on routine provision.
And our last question.
Thank you. In Europe, we have the problem that far too many gay men are still coming in late for HIV testing and are becoming late diagnosed at a time where their immune system is already compromised there. Gus was saying it in his introduction that PrEP could be a trigger also to increase uptake of testing and thereby facilitating early linkage to treatment and care and so on. Is that an argument you are using? Also, I think what we really need is a reform or revolution of sexual health service delivery. I think the type of models we are looking towards are exactly the kind of models that you at least had in the UK sexual health clinics there, which are friendly towards people, gay men and others, or the kind of what the work you are doing in Barcelona. But if you look around in Europe, this is far from the picture there. So my questions are you using the argument that we really to harness the full benefits of PrEP, we need to ensure that it goes together with much easier access to testing, and it can also really improve early diagnosis and care. And secondly, I think that we should not just call for PrEP, we also need to call for a reform of sexual health service delivery and really come up with good models for that. Thank you.
Certainly in the UK, we have argued exactly that in providing PrEP, you're bringing people at high risk into sexual health services for, obviously, HIV tests in the first instance, and then every 3 months, the full range of STI tests, which could well help control STI incidence. And I agree completely on the second point as well.
I just wanted to react on the issue of late detection, which is true, and we have to work on that. But we have to bear in mind that the epidemic is not driven by people who are late detected. The epidemic is driven by people who have acute infections. And that's what we are seeing. In Barcelona checkpoint, in the last 2 years, 60% of the people we were detected with HIV had an infection of less than 3 months. We are progressing on detecting acute infections. There is where the epidemic is driven, and there is where we can see where we can intervene and really make an impact on the epidemic. Work on that and parallel introducing PrEP.
Just to say, I agree on that, of course, but I just wanted to point out also, if we trigger a greater uptake of HIV testing, it will also be to the benefit of people who will come into earlier treatment and thereby reduce their morbidity and eventually mortality.
It's a long discussion, so thank you very much. Yes. Will?
Okay, well, thanks very much, Apostolos. Thanks for you guys.